very much, and for the introduction, and thanks to the directors for inviting me to talk today. I'm really honored to be here, and honestly, it's a privilege to be here. To be here amongst so many giants in the field, and to be able to give my perspective on this, because really what I want to do today is tell you a story, and that's a story about how we can communicate better to deal with what I think is essentially still a black box in all of the great work that you've all done, which is the neurosurgical trauma patients. Okay, no disclosures for me. So an overview of what we're going to talk about today is I'll give you a historical perspective on neurosurgery in general and how we, and from my experience, sort of see, and many of my colleagues see the DVT, VTE thing with respect to neurosurgical trauma. We'll talk a little about when to start and some of the efforts we've undertaken in the past to push that forward a bit. What agent and dose might be safe and effective, that's obviously an open question. I think in this room, the answer is enoxaparin, and I would agree with that, and we're going to talk about that more. But I think in the neurosurgical world, you'd be surprised to learn that is a very controversial thing still. And then, really talk about the fact that we need to treat neurosurgical trauma patients as a specific entity. I think, this is what brought Dr. Constantini and I together when I got to San Diego, is that I wanted to talk about how we were managing the neurosurgical trauma patients and not just manage them the way that we manage everyone else, because whether we've operated on them, whether they've had a subdural, whether they have a subdural and they have an unsecured sinus that has gel foam on it after I, operated on them for 4 hours trying to keep them alive, those are very different questions. When the resident calls me and says the patient's already on 40 milligrams BID of Lovenox, and I know that the only thing holding the torcula together is a piece of gel foam, a discussion is necessary. So going back to this historical perspective, I put this up for you because when I was a resident and I first got involved, simply because I knew that this was the right thing to do for patients, that we needed to push the field forward, this is what it looked like. Patients would come this was at WashU, a major academic medical center. They'd get routine weekly screening Dopplers, and often we'd act on totally asymptomatic infrapopliteal DVTs, which is another issue. There was basically no routine scans for patients coming from SNFs or outside facilities where they may have spent a long period of time. They would get compression devices in the OR, and that became a quality issue, and so then there was even someone in the OR to make sure they were plugged in and turned on and documenting that. But there was totally poor compliance on the floor. You'd have a patient who was hemiparetic and obtunded post-op, and they'd have one ICD on one leg and off the other. And basically, lo and behold, everybody got unfractionated heparin only. It was BID dosing typically. Most of the time started post-op day 1, sometimes 2. And sometimes if the BMI was greater than 40, which in St. Louis, as many of you know, it often might be, they got more. There were IVC filters being placed, again, for a lot of those, asymptomatic infrapopliteal DVTs. We didn't really talk about retrievable or not. That was just sort of the vascular services, concern. And then we started to deal with this issue about HIM reviewing charts and finding these DVTs and calculating ODEs. And so we started to get data like this. And so the long and short of this is a couple of years of data from when I was at WashU that looks at our VTE rate. It was typically around 3%. Now, years preceding that, before we started to adjust our scanning rates to the last question in the last session, I would say it was more like 3 to 5%. And we looked at comparable institutions and said, well, why are we so much higher than them? And the answer was very clear. They don't scan. They only scan. Some institutions, I won't name them. In fact, you're not allowed to order a lower extremity duplex unless you're an attending surgeon. So, they just don't scan. And so, but we wanted this to be better, because what you can't see really well, I think, in that slide right there is our ODEs fluctuated a lot. Sometimes they were around 1 or less the way we wanted them. Other times they were 3, 4, 5, and we wanted to know why that was happening. And so we set up this 7-year-long sort of QI initiative is what it became. And And the idea was to identify high-risk neurosurgical patient populations. That's pretty straightforward, and you won't be surprised when I show you the one slide about that. And we wanted to reduce unnecessary DVT, screening in low-risk patients, and importantly, intervention in those patients. We also wanted to develop a unified protocol for how we were going to manage these patients, because we were a huge faculty and literally everyone did it differently. And it's still that way, frankly. It's still that way in my institution, and it's that way in many. And lastly, also extend that unified approach to how we treat them, because in neurosurgery, we're commonly in that situation. I'm a brain tumor surgeon, or if it's a trauma patient, that we just done an intracranial procedure, and now we have to think about therapeutic anticoagulation and when do we do it and when is it safe. We have rules of thumb, but even those are deeply held by some and loosely by others. So, the high-risk part of this, none of this will be surprising to any of you, right? So things like SIRS and sepsis and UTIs and pneumonia and hemiparesis and spinal cord injury, all these things that when I look at that and from the eyes of this conference, you're thinking, my patients, these are our trauma patients. They have all of these things, with the exception of the brain tumors and those sorts of things. But so none of that was surprising, but we started to put that into sort of a risk prediction algorithm, and that was one part of it. And then the second part was to make some observations. This goes to another comment that was just made about OR time and length of procedures. 67% of our patients that have VTE are time greater than 4 hours. And these are elective patients. These aren't all trauma. These are largely elective patients. And most of them had a mean length of stay up to around 3 weeks, 20 days, and an ICU length of stay around 16 days there. So these were sick patients. And, looking down below there, I listed a few areas that were particularly interesting, which, fatal PE in a septic patient, not surprising, but noted. A 10-hour procedure with a post-op infection and a 42-day stay, sick patients. And the last thing, though, is trauma. And trauma remained, for us at that time, really a black box. Because to say it directly, it was an us versus them, The trauma ICU was a place that we all worked when we were training. It was a place that we didn't work when we were operating, as faculty members and don't round in it all the time. And then there were two completely different cultures. And I think I'll get at what I mean by that a little bit more here. And so moving on to this unified protocol issue, just to show you a few historical things that I hope will get a laugh out of you. This is 2017, and the idea was we didn't know if any of this was perfect, but to Dr. Gert's point, we needed something that everybody was going to do on a regular basis and not deviate so that we could actually study it. And so this was page 1 of a page 2 thing that every resident had to carry, all the faculty had. And the point was is you had to do what was on here. And if you didn't do what was on here, you had to document it and notify the quality officer that was in charge of it. And you'll see a couple interesting things there, I think, and I hope you'll appreciate. One is this was 2017, and as a neurosurgical service, we included enoxaparin on that protocol for spine patients. And in fact, we used to give it to them actually in the operating room or the PACU immediately after the procedure, so long as it was extradural. The other thing I think you might get a smile out of there is if you look at the cranial part on the lower right there, it says that we start with sub-Q heparin, but then we transition to enoxaparin. There was such a pushback in that time to put patients who had had intradural transcranial procedures on enoxaparin that the only way to actually get this on paper was that. And then lastly, with respect to this, on the upper left-hand corner was the trauma black box. Well, we needed something that we could start communicating with our trauma colleagues on, and so we put essentially modified burn Parkland protocol in here so that people understood what it was, and it could conjure up a conversation at least amongst our faculty and importantly our residents about how we were managing the cases. And I'll come back to that a little bit more. And so this is the part that I think it's almost a translation, if you will, for how our minds got wired with data. And some of my colleagues, I should say, minds got wired with data because I think I've read more of yours than ours. There's much more of it to read. But historical studies that I think are important to understand why we in neurosurgery are still debating whether we should use BID or TID sub-Q heparin and not moving forward. And so this is a paper I was just chatting at the break with one of the faculty here about, and it's a paper from nearly 30 years ago by David Frim, who was a long chairman of neurosurgery at the University of Chicago, in fact. So this paper was sort of the quote-unquote landmark paper. If you look at it, it's 130 patients, historical controls. I mean, it's, it's not quite landmark, but landmark for neurosurgery, because what it was it established this 5,000 BID sub-Q heparin standard starting post-op day one. And I'll tell you, that standard still is hard to enforce today, 30 years later. I am not the safety officer in my department, but if I were and I wanted to introduce that, it would still be challenging. And so this showed that there was a reduction in VTE, not surprising, compared to doing nothing. And so and it was basically safe, is the bottom line. And a couple of years later, one of the first papers for neurosurgical patients that demonstrated safety was this paper from Agnelli, and basically using 40 milligrams daily dosing, started 1 to 2 days post-op. Almost all the patients were like between 24 and 36 hours. They demonstrated that there was, bottom line of this is that there was no increased risk of major bleeding, but there was about a 2-fold increase in minor bleeding. So you might see some oozing from around a drain, you might see some oozing from a wound, but the bottom line is they weren't taking these patients back to the OR. And then this study came out around the same time, which if we were going to look at these studies and move forward with them, I think this one set us back a little bit, which was giving BID sub-Q heparin pre-op to patients who are undergoing transcranial procedures for brain tumors. And this study actually had to be stopped early because there was a 25% rate of acute intracranial hemorrhage requiring return to the operating room. When I first started this with one of our emeritus faculty who had been around and done trials in vascular neurosurgery for a long time, this was the only paper that he actually remembered and quoted by name. And so I think these things, although these papers are somewhat historical now, they set a foundation that's been hard to change. And after that, the Europeans started to be a little bit more progressive in neurosurgery. This group was in Frankfurt and Hanover, and basically demonstrated that using nodroparin 2850, which I think, I'm not an expert in this, but if the pharmacists in the room would say that's around 40 milligrams daily, enoxaparin equivalent, that they could do that. They could reduce the DVT-VTE rate significantly, and there was no increased rate of major hemorrhage. They did this again. Sorry, I think I fast-forwarded through that. Well, so they did that again in spine patients as well, and demonstrated the same results effectively. And so for cranial and spinal surgery patients at these two institutions in Germany, it became a standard of care in the early 2000s. And there really weren't much movement with any of the major programs here. This is some data from Michael McDermott, a skull-base surgery colleague who was at UCSF, and he kind of made this move early on to say, hey, for extradural or extraaxial brain tumor patients, I know this is a better drug. I'm going to study it in a small number of patients and demonstrate that it's safe and effective. And that's what he did. And so this also became an institutional standard for extradural, extraaxial brain tumor patients. And so these are the kinds of data that we had. We certainly don't have the volumes of data from large, often retrospective, but some prospective studies as well, like you have. And going back to these risk factors for VTE here that I mentioned earlier, I mentioned trauma was our kind of black box, and I'm going to come back to that now and say we had this Parkland protocol as a precedent for change. We were going to start communicating, we were going to start collaborating and understand what was happening in the trauma ICU. I think this was a big step forward for that. But what quickly became apparent is that this essentially was an exclusion of neurosurgical trauma patients, right? Because the high-risk category is anybody who's had an intracranial procedure. And so all these patients that we're trying to understand and have common ground on, to not just say, well, they can only have 5,000 BID in 3 days or 2 days, and why would we ever start Lovenox on any of our patients? Because it's dangerous. Now they're put in this category that didn't really have any strong recommendations. And so many of them went without DVT prophylaxis. And this paper from 2014, the Parkland paper from 2014, it was 40%. I think that's pretty typical. We'd probably all agree at that time. And in our hands, many of them, I remember getting prophylactic IVC filter placement, talking about it. I can tell you there's a couple patients that I won't go into, but I can remember them having IVC thrombosis from filters, and they're not benign. And, the enoxaparin component of it is great and is the right thing, but at the same time, with the neurosurgeons facing that with trepidation, and now it became schematized in this, it was really more fodder for debate, I think, than it was bridging the differences. I think the TQIP accumulated data so much more rapidly than NSQIP did. You guys became very facile with it and had a lot of power in that data, that you were establishing guidelines. And then the literature became nuanced, and there was this sway away, I think, again, from where I thought we were all going to come together to now sort of not really being in the same lane again. And what it really was a collision of subspecialty bias, right? Neurosurgeons were historically biased towards sub-Q heparin for various reasons, and you all have created all this wonderful data demonstrating so clearly that low molecular weight heparin is superior, and so there's that bias. And, there's minimal evidence in the neurosurgical literature that what you're doing, and so nicely demonstrated for trauma patients, actually applies to neurosurgical trauma patients. Once we're in the head, and once we open the brain, and once we're dealing with the vascular environment of the brain, things change, and it tempers many neurosurgeons' willingness to take risks. And Dr. Constantini and I talked about this actually when we first met, which was in the neurosurgery literature today. There's still really no clear evidence that BID dosing of enoxaparin is safe in neurosurgical. There isn't. Retrospective, maybe, but prospective, there's not. And I think you can imagine where I'm going with that. And also in that same vein, not really any anti-10A based guidelines for these particular patients. And so we started talking about this and what are we going to do and to start to push forward and have some standards in my department and between our departments. And Dr. Constantini and I went to TQIP and pulled the last 5 years worth of patients that had intracranial procedures done, and simply asked the question of how often did they go back to the operating room, and was there an association with them going back to the operating room. And this is extremely preliminary, but it's timely for an important reason because there's a great paper that just came out from Dr. Byrne that basically from these 183 patients, they got most of them 30 or 40 milligrams BID of enoxaparin, some of them unfractionated heparin. 2 of them went back to the operating room for expansion or reaccumulation of hemorrhage, but that was on the day of presentation after an emergent operation based on the immediate post-op CT before they had actually received any anticoagulant drug of any form. And of the remaining patients that went back to the operating room, in fact, 0 of those patients returned for reaccumulation of an intracranial hemorrhage during the immediate perioperative period. In fact, they returned to the operating room for typically unrelated procedures. Some of them got shunts because they had hydrocephalus subsequently. Some of them had wound infections. Some of them ended up having cranioplasties done. And so I think that for me, this opened my eyes to the fact that when you have all this power in the data, the challenge becomes knowing what actually happened to those patients that isn't captured in the data. And again, argues very strongly, I think, that we need prospective data. And so I think going forward with this is all very preliminary. It's just, speaking out loud here, but that, we're planning to do some kind of prospective cohort here in the beginning. Currently, we're giving, after some collaboration, we're currently giving our neurosurgical trauma patients who have had intradural procedures 40 milligrams daily starting 48 hours post-op and not BID. Maybe we'll compare this to 30 BID. Maybe we'll compare this to weight-based. There's many options for that. I think also the main thing is to look at prospectively at some primary endpoints, which are, do we go back to the operating room when we use low molecular weight heparin to a reasonable anti-10A level, or just based on 40 milligrams BID? Are there expansions of intracranial hemorrhages that are any different from the expansions in matched controls that we would see otherwise? And what's the VTE rate in these patients? And what's the rate of death in these patients related to any of these bleeding complications? And the reason I say that I'm going to use a paper that was timely is because while we're talking about this, we have, in a granular way, what TQIP really would say about that. Because Dr. Byrne just did this and published it a month ago or two now, looking at a collection of patients who had neurosurgical procedures. And all of these patients, majority of these patients were treated with 30 milligrams BID of enoxaparin, and asked the question, was early initiation of low molecular weight heparin associated with return to the operating room for repeat neurosurgical procedures? Was it associated with death? And in an adjusted, injury severity adjusted model, what you basically see is that return to the operating room is associated with early initiation of enoxaparin, and death is associated with early initiation of enoxaparin. Now, why is it associated? I think there's a great discussion in this paper in the limitations and the conclusion sections that there are many factors that may be contributing, confounding factors that we don't know. But I think this gets at the fact that when we see data like this, in such a well-powered study, we have to ask the question, what are the confounders, and will we find them in this data? I don't have the answer because I'm not an expert in TQIP. All of you are. I don't think we have it in NSQIP to answer it, but I think in a relatively simply designed prospective study, we could answer this question. So to conclude, I would say that I think we all agree that enoxaparin is a superior medication, particularly when compared to unfractionated heparin for general efficacy. And the literature, clearly much of what was shown today and in other disciplines as well, supports that. But there's a paucity of data about the safety, the dosing, the timing of enoxaparin in neurosurgical trauma patients. And while that neurosurgical trauma compartment is small in the relative scheme of things for all that you all do, for me, it's all that I see, right? And I think we need prospective data. And the reason I think we need prospective data is the consequences of having a expansion of an intracranial hemorrhage are often profound. And so I think while it is a relative small aspect of the overall picture, I think the consequences can be severe. And so I think in the interim, we have to continue to practice with additional discretion regarding drug selection and timing of starting it after intracranial, intradural, neurosurgical, and spinal operations. And definitely additional prospective data is warranted to begin to understand this question. There are many patients, I can tell you, that fall through the cracks. There are patients who have a procedure, have a poor performance status, have an expansion of a hemorrhage on a scan, and never go back to the operating room. They're not going to get caught in a retrospective study because they're never going to go back to the operating room. They're not going to see anybody in clinic, and we don't know how long they survive. Same thing with spinal epidural patients. There's not many of them, but they exist. And so with that, again, I'll thank you for inviting me here. It's a privilege, and I'm happy to take any questions.
Thank you so much. Questions?
Lottenberg, he's asking if within 24 hours is not appropriate, is 48 or 72 hours appropriate?
Yeah, well, I guess it depends on the data. So in the context, some data would suggest that 72 hours might be the inflection point where we go from a daily risk reduction of 28% to 15%. I think there's a lot of data that we could lean on to answer that question. I say that because I take brain tumors out of patients 2 days a week and operate in the head regularly, and I start every one of my patients on VTE prophylaxis post-op day 1. And so this is a wonderful dueling question because now I'm leaning the other direction, saying I'm the aggressive one here in terms of what we're doing. I think it depends on the agent, and I think it depends on the case, but 24 to 48 hours to me seems like the optimal time.
Yeah, that was really a terrific discussion. I think you provide a concise, very clear recommendations from a neurosurgical perspective, and I very much encourage you to continue publishing in the trauma box. way you deliver it, I think, is probably helpful to us and the neurosurgeons. Side, your chair was on my service at USC, and he was just as terrific. So he's hiring people in his own light, and I'm going to take all the credit. But, you know, regarding the burn paper, because I think that's gotten a lot of press, and the pendulum swings both ways. And as mentioned, that came in light of previous papers that had different findings. I don't think there's going to be an answer. I think more research is needed. But when I see death as a marker of association, there can't be causality to that. I'm really concerned that the cohorts were different. That aside, it really does strike me that that paper does do more than the modified Burn Norwood or Parkland have. It seems like it advances that. Would you agree or maybe comment?
Yeah, absolutely. I think it does. And what was interesting to me about it is there was not an increased rate of bleeding. There was no difference between enoxaparin and unfractionated heparin. And curiously, in the intervention groups, and the author is here, so correct me if I'm wrong, but in the intervention groups, craniotomy or craniectomy actually was not significant. It was actually the drains and the monitors that were. And so, again, I started to think through all the permutations. Injury severity, no, corrected for injury severity, right? So I don't have a good answer for where that death comes from. My Gestalt impression is it has to come from severity of injury, and it has to be patients that maybe weren't aggressively managed initially, but we don't know, and that's the challenge. We can't go back and figure that out easily without granular dives by MRN, right? And that's why I think it would probably be best to do a prospective study and answer the question.
I just had to, This was a really great talk, and actually it's so refreshing to hear the neuro perspective. I have a quick comment and then a question. Specific to the paper, I think the number one thing that it shows is that just the lack of granularity at the patient level. Associations are important, and I think serve as a sort of to do the prospective studies that you're talking about. The association with death was really just in one small subgroup, which itself was interesting. I think the entire cohort, there wasn't that association, and that was really so obviously a very morbid question that I have is, do you think that the modified burn is still something that we should be using, or should we sort of endeavor to flesh that out a little bit more? High risk group is such a little bit of a. I wonder what you think of that.
Yeah, thank you again. Perspective. Yeah, I think you're absolutely right. I would agree that with how would I put it? It's a bit restrictive in the end, right? Because we take these patients who are high risk and we put them in a box, and then we don't publish specific guidelines for how we manage them. So I do think that we need to update what we do with the high risk patients and not just sort of put them case by case basis, but establish more which patients can safely receive treatment and which can't.
I was going to add the same question that Dr. Stein asked me. Like, there is differences within neurosurgeons to, not aggressive. I mean, of like consistency within your subspecialty.
I think there's sort of a two-pronged approach is what I kind of have in mind. And the first is to do what I hope to do here is the same thing that we did at WashU, but do it even methodically with a partnership with Dr. Constantini, so that we can absolutely, as an institution, as a center, have agreement across the neurosurgical trauma and neurosurgery space. And once we have that, and particularly with Dr. Constantini's experience, the TQIP database, we collect enough prospective data that then someone like myself could go to the neurosurgical societies and say, let's write the guidelines for the way in which the American Academy of Neurological Surgeons proposes the management of patients with VTE Prophylaxis post-cranial surgery, post-extradural surgery. It's really interesting, as a side point, I'll tell you, that I don't know how it looks at your institution, but a lot of institutions place a lot of bolts, and a lot of institutions don't. And, you know, the standard recommendation from the AANS guidelines for neurosurgical trauma patients is to get an external ventricular drain. And I particularly like them. And when placed well, they work well. They transduce intracranial pressure more reliably, and they also give you a pop-off valve that will sometimes get patients with diffuse trauma through without a craniectomy. But they're not done all the time. So I think then somebody pushing the data on the Neurosurgery Society side will also be necessary.
I think one comment, I guess. I mean, I think there's areas where we should all be able to agree based on the data, and that's in the sort of low, medium risk. I think we still have a challenge to, despite fairly compelling data, to get everybody on the same page, even for those low and moderate risk. So I guess the first question for you is, how do we do that? Because we all struggle with it. We all point to the same papers. You know the papers, and I hear you agreeing with that, but we still have trouble moving the needle on that. That's my first question. Then my second question is, there is a lot of ambiguity in the higher risk patients. So where's the money at for that first prospective trial? Is it the severe people in the Burr-Norwood, box to the right? Is it operative trauma patients? Where should we direct our attention where we're going to get the most bang for it?
Yeah, that's a very good question. I think that the first issue would be to apply to neurosurgical trauma patients in the high-risk group what we know works, and do it and ask the question if in that group as in aggregate, particularly those that have had intracranial surgery. When I reply to the high-risk group, I'm referring to those that have intracranial surgery. Can we treat them aggressively, and is there an increased risk of postoperative hemorrhage, actionable postoperative hemorrhage? And the reason I think that's important, because if we had some solid data that we could take back to neurosurgical societies, I think that we would have buy-in. I don't want to self-categorize as a neurosurgeon, but I think if there's hard evidence, they'll take it. If there's not, then that sort of clinician gestalt kind of comes back into play. And then I think there's always going to be some of those patients that are absolute case-by-case basis. We get some of them, gosh, I could think of several cases that you can't dream them up. And they have so many competing factors that there will always be a handful of those sort of hyper high risk. But I think the high risk category now is an aggregate, a lot of which we probably could treat more aggressively, safely.
I have more of a comment than a question. I don't want to be that guy, but as you were talking about, like, you want to bring guidelines from the neuro societies, and I hear other people talking about guidelines from ACS, COT, EAST, et cetera, I would just push really hard that instead of having your guidelines and my guidelines, we try to do it together. Because I think if we could all agree in patients that we share between neurosurgery, trauma surgery, same thing with orthopedics, I know we're same kind of questions. One guideline from the groups together, speaking the same voice, I think is great. Because we've all seen guidelines that have different answers. Someone brings, well, my guideline says this, and my guideline says that. It's really hard. But I would love to see something, ACS, COT, AAST, neurosurgery group A, neurosurgery group B, et cetera, et cetera. So just a push in that direction for literally the leaders in VTE right here.
Yeah, absolutely. I would welcome that.